I think Dr. Ramesh is here, so we can start with the first talk. What should be the first line treatment in DME patients? So, Dr. Ramesh, please.
Yeah. Thank you so much. Thank you to Bayer for giving me this opportunity. And the topic of today is quite interesting. What should be the first line of treatment in DME patients? And we know that the vision problems in diabetic retinopathy is basically involving macular ischemia, diabetic macular edema, TRD, and vitreous hemorrhage. But we'll be focusing on something which is very common in diabetic retinopathy cases, that is the diabetic macular edema, which happens because of the breakdown of the inner blood retinal barrier, which leads to leakage and fluid accumulation in the inner retinal spaces, mainly from the microaneurysms and also from the increased capillary network or capillary permeability. VEGF and placenta-induced growth factor, that is the PLGF, they both drive the development of macular edema, especially in vascular diseases, mainly the diabetic retinopathy and retinal vein occlusions. And these VEGFs, they are responsible for activation of the microglial cells and then subsequently chronic inflammation and RP cell damage. And the VEGF is also important in breaking down the blood retinal barrier, which causes the vascular leakage and subsequently the development of the macular edema. So both VEGF-A and the placental induced growth factor, they act through the VEGF receptors to play a critical role in the development of edema, the increased permeability, increased inflammation, and subsequently the neovascularization. So it is actually the increased permeability which happens because of the VEGF-A and the placental induced growth factor, which were responsible for the development of the macular edema. So thus the treatment of macular edema would be following a diabetic retinopathy would require the inhibition of these VEGF-A and the VEGF-B and the placental induced growth factors. And aflibercept is the only drug which blocks the VEGF-A receptors and the PLGF. And you can see here, in comparison to the other drugs which are the ranibizumab, brolucizumab and faricimab, aflibercept is the only drug which blocks against the VEGF-A and the PLGF, and it does not block the Ang2 receptors. What's also important is that the half-life of the drug is much more compared to the other anti-VEGF molecules. Now, let me just talk briefly about faricimab here, because it's important, because people are going to talk about faricimab in the near future. And what faricimab does is it's basically an Ang2 receptor blocker and a VEGF-A receptor blocker. So what you need to understand is that the Ang1, which is actually a good molecule, it's a good molecule because it helps in maintaining the vascular integrity and thereby prevents the vascular leakage from happening. But when there is increase in the VEGF, when there is increased production of the VEGF, the Ang2 receptors, they get activated, and then they cause the pathological situations where there is a stress on the capillary permeability, and therefore there is increased leakage. So it is the increased or the elevated VEGF levels which are going to drive the Ang2 production and then subsequently the neovascularization and the capillary permeability. This is the important slide which tells you that when there is a low VEGF, it is the Ang1 which is present and which is responsible for an intact blood retinal barrier. But when there is a high VEGF, it is the Ang2 which comes into play, and it causes the breakdown in the blood retinal barrier and subsequently the development of the macular edema. So when you look at from a clinical perspective, it is a low VEGF state which can be achieved by effectively suppressing the VEGF with a long-acting anti-VEGF molecule such as the aflibercept, and this may reduce the potential therapeutic value of the added Ang2 blockade. Also, the role of faricimab, we have a lot of trials which have spoken about it, the Yosemite and the Rhine trials, which have actually spoken about the role of faricimab in DME and neovascular AMD. But the contribution of this Ang2 inhibition in the development of macular edema is still not very well understood. So we really don't know how much Ang2 actually plays a role in the development of macular edema, especially in diabetic retinopathy. So aflibercept should be considered as the first choice of anti-VEGF in the DME management. But in real world setting, is aflibercept the first choice? That is something which we need to answer. And what we did is we just looked at our data in the last 1 year, that is from 4th May 2022 to 4th May 2023, and we found that we gave around 674 Eylea injections or aflibercept injections in 320 eyes, and only 25% of these eyes were having diabetic macular edema. So we gave very less number of patients with diabetic macular edema aflibercept as the treatment. And out of these 79 eyes, it was only 29 eyes who received aflibercept as the first line of therapy. That means we are actually giving less than 10% of the patients aflibercept. This is the real world setting. This is the fact which I'm going to tell you. But let's understand what the reasons for this mindset is. Why are we not giving aflibercept or an Eylea so frequently? So that's the reason is because we have a lot of trials which have spoken about the various ways you can manage a diabetic macular edema. In diabetic macular edema with good visual acuity, that means when the vision is between 20 by 30 and 20 by 50, we feel that any anti-VEGF is effective. That is what the protocol T of the DRCR net tells us. We reserve aflibercept for patients who are having visual acuity less than 20 by 50. That is again the protocol T which tells us. Patients with early DME, where you have an early center involving macular edema, where the visual acuity is better than 20 by 25 or equal to 25/25, the protocol V of the DRCR net tells us that observation is a good enough treatment compared to aflibercept. We reserve aflibercept only for patients who are not responding to other anti-VEGF molecules. DME is treated on a PRN basis and not on the loading dose basis, which we usually treat it for AMD. We believe that good metabolic control alone will reduce the need for injections in DME. We reserve only for patients aflibercept for patients who are unlikely to come for a monthly follow-up and who require a longer duration of action. And we all the time we believe that the aflibercept is not affordable to the patients. So let's look at each myth and then try to counter those myths with the clinical trials which have been recently published. So the first myth which we have, it's not a myth per se, but it is aflibercept is effective in DME with visual acuity less than 20 by 50. So this is the data which comes from the protocol T, or the subgroup analysis which comes from the protocol T of the DRCR net, where you can see that for patients who are between with the baseline visual acuity between 20 by 30 to 20 by 40, the visual acuity, the gain or the ETDRS letter gain is almost the same irrespective of the choice of the anti-VEGF molecule which you use. But when the visual acuity falls below 20 by 50, you can see that there is a huge difference between aflibercept and the other comparative molecules which you have, where aflibercept actually achieves around plus 19 ETDRS letters compared to an bevacizumab or a ranibizumab, which achieves around 12 and 14 letters respectively. Now let's look at this in detail, and when you look at the entire cohort of patients, irrespective of the baseline visual acuity, aflibercept is still much better than the other comparative groups. But what you need to understand is the number of patients who require focal laser in patients who are being treated with the other anti-VEGF molecules. So you can see that patients who are treated with aflibercept, they require much lesser focal or a grid rescue laser treatment compared to patients who are treated with bevacizumab and ranibizumab, and this was a significant thing which we need to look at. So the first take home from the first myth which we get is that aflibercept should be the first choice with any baseline visual acuity. It is effective in 20 by 50, yes, agreed, but it is also equally effective in patients who are having vision between 20 by 30 and 20 by 50. Now the second myth which we have is patients with DME which have a very good visual acuity, and when we say very good visual acuity, we are telling about visual acuity which is equal to or better than 20 by 25, and where our understanding is observation is a good enough treatment compared to aflibercept. And the reasons are because of this data or this charts which come out, which says that the 5-letter loss is equal in both the groups, the 10-letter loss at 2 years is equal in both the groups, and the 5-letter gain is equal in both the groups, and therefore we conclude that observation is not inferior to anti-VEGF or aflibercept in the protocol T, in the protocol V study, or even in these studies. But what people don't look into in detail is the number of patients who are reaching the visual acuity of 6 by 6 with aflibercept injections. And you can see with aflibercept, you have almost a 77% of patients who are reaching the 20 by 20 or greater than 84 ETDRS letters compared to observation group. So this is a very, very important point, that aflibercept means observation should not be considered as a treatment. It should be aflibercept should be considered even in patients with good visual acuity. Again, look at the change in this subfield thickness or the retinal thickness, and you can see at the end of 1 year, the thickness reduction is much better with the aflibercept molecule, and even it is being maintained at the end of 2 years in these cases. Now let me show you 3 cases which we found, and where the patient's visual acuity was ranging between 6.6 and 6.9, and this is how the OCT patterns were at presentation, where you can see most of them had center involving diabetic macular edema, but the case 3 had a much significant amount of central retinal thickness compared to the other 2 groups. And the first case was observed, the second case was treated with topical NSAIDs, and the third case was treated with injection of aflibercept. And you can see the response which you are getting at the end of 1 month following the treatment in these cases, where you can see that there is a complete reduction in the macular edema with the aflibercept injection. So the second take-home point which I wanted to give is that it should be considered also as a first choice in patients with very good visual acuity, unless there are some other factors which need to be taken care of. The third myth is that aflibercept should be reserved only for patients with poor response to other anti-VEGF molecules. That is, we always try to keep aflibercept as a drug when, or a brahmastra, when nothing else is working, no anti-VEGF molecule is working, and that is the time when we try and use aflibercept. And yes, there are papers which support this, which clearly say that in patients who are unresponsive to previous anti-VEGF therapy, aflibercept is a better option, and it helps in achieving an improvement in both the functional and the anatomical outcomes. So what we found with the three things is that it is useful in treatment-naive cases, and it is also useful in treatment-resistant cases, and therefore aflibercept can be considered in either of the two situations. The fourth myth is that DME is not AMD. AMD is something where you need more loading doses, whereas DME is treated on PRN dosing. And this is where we need to understand and explain the importance of early and intensive therapy. And the best way to understand early and intensive therapy is the protocol T results of the DRCR net, which basically compared the three anti-VEGF molecules, the aflibercept 2 mg, the ranibizumab 3.3 mg, and the bevacizumab 1.25 mg. And where at the primary endpoint, you looked at the change in the visual acuity from from the baseline to year 1 in these cases. The protocol T also had a very proper regimen of retreatment. They had a very strict regimen of retreatment of how you treat these patients, when the macular edema is there, when do you inject, when do you defer treatment. They had a very strict protocol. Now let's look at the results which come out of the protocol T, and you can see this very clearly. At the end of 1 year with aflibercept, the visual acuity gain when you are giving monthly injections is around 18 letters or 19 letters, which is even sustained at the end of 2 years when comparison to the other anti-VEGF molecules, that is the bevacizumab and the ranibizumab, where the visual acuity gain is much lesser. But what happens in patients who have a better visual acuity? The visual acuity gain is almost similar, but it is still better than the other anti-VEGF molecules. Let's look at the central retinal thickness reduction. The reduction is much better with the aflibercept molecule at 1 year, and also at the end of 2 years, where it is more superior compared to the other anti-VEGF molecules. Now, patients treated with aflibercept experience a significant or considerable reduction in the central subfield thickness regardless of the visual acuity. So this is a very important slide which tells you that irrespective of whatever the vision is, the central subfield thickness, when you are treating early and intensively at a monthly interval with aflibercept, the reduction in the macular thickness is much significant, much better than the other injections or the other anti-VEGF injections. Also, the number of injections which you require with early and intensive therapy is much lesser at year 2. So it is very important when you are treating year 2 aflibercept, the number of injections which you require with aflibercept is much lesser than the other anti-VEGF molecules. Now this point is again further confirmed, or further you can say it is fortified with the VISTA and the VIVID and the VISTA studies, which basically compared the aflibercept at the 2 weekly 4 weekly dosing and comparing the 8 weekly dosing against the sham group. And again you can see that when you treat these patients early, at the first month itself there is a significant improvement in the ETDRS letters. Around 5 letter ETDRS improvement is happening, and when it comes to at the end of 1 year, there is a 11 letter improvement, and then which is being sustained over a period of 3 years. And this is the same which is being shown with the VISTA studies as well. And this data tells us that around 80% of the patients, they show more than 5 ETDRS letter improvement when they are treated with monthly, at least 5 initial monthly dose therapy. Now this is important because these improvement in the visual acuity is sustained over a period of the second year and the third year as well. So patients who are treated early, the visual acuity gain is being sustained over a period of the second year and the third year as well. So intensive therapy in the first year itself with aflibercept, it shows significant visual improvements that are maintained over a long-term period, especially in year 2 and year 3. Now what happens When you treat late, what happens? This is a very important thing. So when you look at the red box where these are the patients who were in the sham group, when they were treated late, they were not treated initially, and they were treated after a period of 2 years, and you can see that the visual acuity which was improving in these cases were hardly anything. So delayed treatment did not achieve significant ETDRS visual acuity improvement. This is further fortified with our study itself, which came from the NN group, where what we said is about the retort study, where we said that patients who were treated for more than 6 months later, they had the worst visual outcomes and they required more number of injections. So this is something which we have published as well. So delaying the anti-VEGF treatment may lead to irreversible loss of vision. So the fourth take-home point which I wanted to tell is the early and the intensive therapy is definitely superior to late and incomplete treatment in DME. The fifth myth which we have is that it's not cost beneficial, and this can be addressed by the ILIA for You program, where you basically, these are patient support programs where you initially pay for the 2 injections and the remaining 3 injections get free of charge. So when you have good patient support programs from the company itself with long duration of action and longer treatment free intervals, aflibercept turns out to be cost effective as well. The sixth myth which we have is that when you have multiple injections, you end up with multiple side effects. And when you compare it with the Kite and Crystal study, you found that the number of injections or the number of side effects, ocular adverse events were much lesser with the brolucizumab group. And therefore, the sixth take-home point, I would say it is a safe drug. So to conclude, I would just say that aflibercept should be considered as the first line of treatment in DME because ILIA is effective. It gives a Yahoo kind of an effect. It is long lasting. It seems to be economical, and also it seems to be all right and safe at the end of the day. Okay, so thank you very much. Thank you for your kind.
For nice presentation. I think we'll have a discussion on this, and the first question which I would like to put forward to here, I think we have all the panelists now, is what determines the first choice as far as the anti-VEGF in DME is concerned? I start with Dr. Mahesh Shanmugam. Mic, please. Is there a mic there? You have to give a...
The only thing that stops people from using it would be the initial cost. Otherwise, like aflibercept possibly is better in every other way. So given a choice, I would prefer starting the patient with aflibercept.
Yeah, anybody else? Yes, Hemant.
Yeah, I would agree with him. See, I think our choice has been driven more the patient's requirement and the economical factors. But let's say if that is taken off, especially in insurance patients, aflibercept would be the...
Ashish and George and Ashish. George.
Yeah, to the point which Ramesh raised on recalcitrant cases, it was in the beginning. Now it is no more, that time the cost was the major issue. Even for now, there is no, naive affordability is the only thing which determines what is the first line. There is no doubt the safe and effective molecule is aflibercept currently, and unless we have more, more potent ones with safety and longevity, so to reduce the burden, DME we need to treat for at least 2 to 3 years. And this loading dose, it's come from the DRCR protocol. That is what I wanted to start. It is not like 5 injections or 6 injections until the macula dry and plus maybe one more so that the visual acuity maximizes. So because that is the best current protocol to reduce the number of injection rather than treat and extend. So most of these trials have used, including Vivid Vista, everything use that protocol. So I would rather stick to DRCR protocol than treat and extend.
Dr. Ashish, anything?
Nothing, sir. I think what Dr. Mahesh and he said exactly the same.
I think that's the major thing, affordability. Otherwise, yes.
Yeah. Because the duration of effect is so long that the number of visits and number of injections also comes down. So our treatment burden goes down with a drug like aflibercept.
Yeah, but what has come out is that the problem here is the cost. You would like to use the best drug.
Initial
You
cost.
want to use, and
It's only the initial
perhaps the
cost.
use has gone up. Many of us are using as a first line now, since the cost, it has become more cost effective. So that is what basically, and durability, of course, is subsequently what will come. I had another question to the panel, which is, I think one of the thing raised here is about observation and good visual acuity and giving the injection. So again, I start with Dr. Mahesh. So do you give injection, or I think these are some of the important issues perhaps where we.
At the present moment, I'm not giving injection in very good vision, but that's like if the patient has been followed up by me, and if the patient is presenting to me for the first time with good vision and edema, I would probably not inject right away, but see the patient on a closer interval. So about a month later or 6 weeks, and if I find that edema is going up and the vision is still the same, I'll probably start injecting, but I don't start injecting right at the initial moment when I see the patient with good vision.
Dr. Hemant, yeah.
I would also look into the systemic status, and if that needs to be corrected, I would probably go for that. And I also look about the reliability of follow-up. So there are also that reliability issue in some of our patients, especially if they're outstation and they're unlikely that they're going to come for follow-up. Then I need to take a decision on it. But I think I always treat the patient by the vision, primarily, not by the OCT.
Yes. Dr. George?
I would observe the patient, then injection. You have to, risk benefit ratio has to be given to the patient. If this 20 by 25 vision is actually 6 parts, that is better than 6/9. So the patient has to understand that these injections are not one time, it has to be multiple. If he understands the concept, then it has to be in discussion with the patient. Otherwise, I'll observe with time, because we are not losing the vision. We are keeping the patient on follow-up, and at any time, he also understands, then start the injections like the same protocol what he discussed.
Yes.
If it comes to 6/9 or.
Dr. Ashish, yes.
Means, yeah, I always observe these patients, because we know the data that even best of the best trials, even best of the trial data, at the end, after 2-3 years, you have 30 to 60% of patients having persistent edema. If you have that kind of IRF staying for so long, so it's unnecessary that we treat patients with good visual acuity.
Great. Yeah. Yeah, that he has shown that trial, but at the same time, that is what. So what I would like to say here is, which has come from all the panelists, that don't treat the OCT. Please don't treat OCT. We are treating OCT these days. That is where the crux of problem is. So treat a patient. I think somebody mentioned about the metabolic control and other things. We have to look at those things rather than just looking at OCT.
And it's not just the cost; it's also the risk. There is a
Yes,
risk of
yes,
endophthalmitis.
yeah, that's what I'm saying.
In a
So many
6/6
things.
eye.
Yes, very true, very true. I think we still have a little time there. I think I'm going off the track here. I think he mentioned topical NSAIDs. How many of you use topical? Has they got any role? Quick, this thing, Mahesh.
Not in addition to the anti-VEGF agent, but if the patient, like Hemant mentioned, the systemic control is not there, and I want the patient to go and come, or the patient doesn't want injection, I probably try NSAIDs. But I think there are studies to say that NSAIDs have shown some effect on the edema.
Yes.
I would
Just a minute.
I would probably just look at it, especially in a patient who has just undergone cataract surgery and having some edema where you are doubtful whether it is post-surgical or is it. Other than that, I don't use it.
Okay. Yes, George.
If I decide to observe that patient for whatever reason we discussed, then I put the patient on NSAIDs.
And Dr. Ashish? Okay. Dr. Malika? Yeah. Okay. Thank you.